Hello, welcome. As we take a look this week at Chapter 5, Assessment and Diagnosing in Counseling. Diagnosis in counseling has a long history that dates back to ancient civilizations. In ancient Greece, for example, Hippocrates, the father of medicine, developed the theory that imbalances in the four humors, blood, phlegm, yellow bile, and black bile, could lead to mental and physical health issues. Well, this theory laid the foundation for the concept of diagnosis in counseling, believe it or not. Throughout history, the understanding of mental health and the methods of diagnosis, of course, have continued to evolve significantly. In the Middle Ages, mental health was often attributed to demonic possession or moral failing that led to harsh treatments, exorcisms, torture. It wasn't until the 18th and 19th centuries that mental illness began to be seen as a medical condition that could be diagnosed and treated using scientific methods. The development of the field of psychiatry in the 19th century marked a turning point in the history of diagnosis and counseling. We think of psychiatrists as Kraepelin, Freud, right? They pioneered new theories and techniques. In the 20th century, advances in psychology and psychiatry further refined the process of diagnosing. The Diagnostic Statistical Manual of Mental Disorders, the DSM, was first published in 1952, and it provided this standardized classification system, right? And of course, it's been revised several times. I know that we took a look at that, and I walked you through a bit of the context of those changes in one of the other chapters. We're going to do a little bit more to that briefly in this chapter discussion as well. We know that diagnosis in counseling is nuanced, it's complex, and requires that we have a thorough understanding of our client's personal history, symptoms, and needs, and that we use a variety of assessment tools and tests and techniques to gather data, to gather information, and we've been talking about that and the various methods of assessment and testing. We also need to consider the cultural, social, environmental factors that influence a client's mental health. Counseling and psychiatry have come a long way in terms of their development. Both fields have evolved significantly with advancements, of course, through research, treatment, and the overall understanding of mental health. Frank Parsons is widely recognized as the father of counseling and guidance. His work in the late 19th and early 20th centuries laid the foundation for the modern practice of counseling, which continues to shape the way we approach helping others navigate life's challenges. Parsons was born in 1854 in Boston, Massachusetts. He went to study law at Harvard. However, he soon found his true calling in helping others find their paths in life. Parsons believed that individuals should have the opportunity to explore their interests, their abilities, and values in order to make informed decisions about their education and their career choices. In 1908, Parsons founded the Bureau of Vocational Guidance in Boston. This was the first of its kind in the United States. The Bureau provided counseling and guidance services to individuals seeking help with career planning and decision making. Parsons emphasized the importance of self-assessment, goal setting, and exploration in the career development process. Parsons also developed the concept of trait and factor theory, which suggests that individuals should match their personal traits with the requirements of a particular occupation. This theory laid the groundwork for modern career counseling practices. So throughout his career, Parsons was a pioneer in advocating for the importance of vocational guidance and counseling. And that was, of course, in various schools, colleges, universities, right, educational settings. He believed that individuals should have access to counseling services to help them make informed decisions about their future. Further history of the field of counseling can even be traced back to ancient times when individuals sought guidance and support from clan leaders, clan in clusters of communities we think of our ancient civilizations, the elders of the community, the religious leaders, the healers. Counseling, though, as a profession, really began to take its shape in the early 20th century. So we mention Freud and Jung, who laid the groundwork for modern counseling theories and practices. We know that counseling, of course, encompasses a wide range of approaches and techniques. We use evidence-based methods, whereas psychiatry, on the other hand, focuses more on the diagnostic and treatment of mental illness through medication management, right? Therapy and other interventions. Psychiatry has also seen significant advancements in recent years. Of course, the ongoing development of new psychiatric medications, neuroimaging techniques, we have genetic research. All of these things have improved our understanding of the brain and its role in mental health. One notable development in both counseling and psychiatry is the shift towards a more holistic approach to mental health care. This means we're considering the whole person, mind, body, and spirit, in the assessment and treatment of mental health. So this approach really recognizes the interconnectedness, right, of mental, emotional, physical health, and aims to address all aspects of a person's well-being in the healing process. We also know that advancements in technology, right, have played a significant role in the ongoing development of counseling and psychiatry. Telehealth services, online therapy platforms, mental health apps have all made mental health care more accessible and convenient for people, for individuals who may not have access to perhaps traditional in-person therapy. Nosology is the branch of medicine that focuses on classifying diseases and disorders. There's a great answer for your next appearance on Jeopardy! What is nosology? So the history and philosophy of nosology date back to ancient times. I mentioned those early healers, right, who attempted to categorize illnesses based upon observable symptoms. So the concept of nosology evolved over the centuries and led to the development of a modern classification system, very much like we identify in the Diagnostic and Statistical Manual of Mental Disorders, the DSM. The origins of the DSM can be traced back to the mid-20th century. We have to go to the American Psychiatric Association, who recognized the need for a standardized classification system. As I mentioned a few moments ago, the first edition was published in 1952. It contained a list of 106 disorders. As we know, since then, the DSM has undergone several revisions to reflect advances in our understanding of psychiatric disorders and their treatment. The philosophy behind the DSM is grounded in the belief that mental disorders are real medical conditions that can be diagnosed and can be treated. So by providing a standardized set of criteria, the DSM aims to improve the accuracy and reliability of these diagnoses. This, in turn, allows for more effective treatment and better outcomes. The DSM is organized into different categories, each disorder assigned a specific code and set of diagnostic criteria. These criteria are based on research and clinical observations, and they're intended to provide a consistent framework by which we diagnose mental health across various different continuums of healthcare settings. Critiques and critics of the DSM argue, of course, that the manual can become hyper-focused, if you will, on symptom-based diagnosis, which could lead to overdiagnosis and the pathologization of normal behavior, right? They also raise concerns about the influence of pharmaceutical companies on the development of the DSM and the potential for diagnostic labels to stigmatize individuals with certain or any or all mental health conditions, right? So despite these criticisms, the DSM remains the most widely used influential tool. It has shaped our understanding of mental illness and does provide clinicians with a common language, thereby which we can discuss and diagnose. The DSM third edition, the DSM-3, was a groundbreaking publication which had significant impact on the field of psychology and psychiatry. It was released in 1980 by the APA and introduced this standardized system for diagnosing disorders that revolutionized the way mental health professionals approach diagnosis and treatment. One of the key aspects of the DSM-3 was the establishment of clear diagnostic criteria. Prior to its publication, there was a lack of consensus among mental health professionals on how to diagnose and classify mental illness. So the DSM-3 provided that standardized set of criteria. Another important aspect of the DSM-3 was the increased recognition and understanding of mental health disorders themselves. By providing a comprehensive, detailed list of the diagnostic criteria, the DSM-3 helped to raise awareness and, some would say, to begin to reduce stigma a little bit, right? It helped to facilitate research and communication among mental health professionals because it did provide this framework and a common language. It also, the DSM-3, influenced the field of psychiatry. It influenced treatment approaches and drug development. Thereby, we were able to have clinicians be guided with appropriate treatment interventions, development of new medications and new therapies for mental health in various conditions, and also provided a clear understanding of the real underlying mechanisms of mental health disorders. The multi-axial assessment system, when was in place, the psychiatric problems were described on 5 distinct axes. Axis 1 included disorders that were more episodic. Axis 2, disorders that were thought to be more stable or long-lasting. Axis 3 and Axis 4 provided a place to list medical conditions, psychosocial environmental problems, all relevant to the mental health issues. And Access 5, known as the Global Assessment of Functioning, GAF scale, provided clinicians the opportunity to place clients on this 100-point continuum describing their overall level of functioning. Many people played significant roles, but the most significant were those on the task force, right, for each of the editions of the DSM. The group consisted largely of researchers in various specialties within psychopathology. They were, of course, selected for their expertise and their scholarship. The task force consisted primarily of psychiatrists, some psychologists, and mental health professionals. Now, the DSM-5 and all previous editions have been published by the American Psychiatric Association. This, of course, is different from the American Psychological Association. So, although the DSM had been used extensively by clinical psychologists and a wide range of other non-medical mental health professionals, we think of social workers, etc., the authors who have had the most significant impact on its contents are really medical doctors. The term dysfunction in mental functioning was indicated, usually associated with a significant distress or disability in areas of functioning. There, of course, was a title change in the DSM-5. The authors deliberately shifted away from the traditional Roman numerals used in the previous editions toward the Arabic numerals instead. And I know I referenced that and talked a little bit more extensively about all these editions in a previous chapter. But the reason for this shift, I believe also that I highlighted, so that we could make minor updates, and that would be able to name just to change and adjust changes to computer operating systems, right? And the application. So the DSM 5.1, DSM 5.2, etc., right? So the name really isn't just superficial, that change from the Roman numeral to the Arabic number. So, in other words, the DSM is a living document that in the future will be more quick to respond to new research, improvements of our understanding. We'll no longer have to stick with this single static version for like a decade, 15, 20 years until the next time arise for a major revamp, but rather instead now they'll be able to make smaller scale changes more continuously. I also noted in one of the other lectures that the multi-axial assessment system was dropped within the DSM-5. This also brought a number of important changes to the way we diagnose clients. Also, Access 5, the Global Assessment of Functioning, right, the GAF scale was eliminated. Let's see. We'll talk about here in just a little bit the new classification system or the new assessment tool that was incorporated. And the other aspects that I referenced in another lecture on the cultural sensitivity. And we're going to see a few more of those here in just a little bit. The use of biological markers as diagnostic tools. So initially, the authors of the DSM-5 considered significantly overhauling the manual. And that would have been a significant paradigm shift from the way we define mental disorders. But it became evident that mental health lags behind, right, other specialties. So although there are many mental disorders that involve biological factors, those disorders lack the definitive, reliable biological markers, if you will. The kinds of things that they indicate there's this like test positive, test negative, right, in this conclusive way. So biological markers may become known in time as neuroscience advances, but for now, research has simply not yet uncovered them clearly enough. And so we know, and what we've said is the DSM-5 has been written for, well, it was written and published the 2013, and thereby not for 2063 or 2113, because by then, the way technology and research and the ongoing understanding of the brain and neurology works, there certainly could be connections that are identified between mental disorders and neurological or biological underpinnings, and thereby maybe perhaps making that shift in terms of the biological biomarkers connecting mental illness, mental health issues with neuroscience. Another across-the-board change that the DSM-5 authors considered was a shift towards a dimensional classification. It involved viewing disorders not strictly in a categorical yes or no way, but rather a continuum. In other words, rather than describing a client only as either having or not having, the clinician could rate the client's depression symptoms per se, right, on this scale. Well, that idea was rejected. We're just too mature, too complicated, not there yet. Maybe something for future editions. Also, the dimensional approach was considered for different subsets of mental disorders, specifically personality disorders. There was research that had been accumulated and suggested that personality disorders fit into dimensional as opposed to categorical. So the DSM-5 authors proposed a specific way of understanding personality in a rather dimensional way. But again, that proposal was rejected, too complex, not clinically useful enough. So again, there could be more research, more study that will lead to different proposals of the way things are classified in future editions. But we do know, and we do need to be keenly aware that we have an ethical, obligational role to our profession in terms of diagnosis and assessment and treatment of our clients, that we steer away from that pathologizing, the stigma, the overdiagnosis, misdiagnosis, right, in ways that were that make that diagnosis and the DSM, we're there to serve it. Rather, it is a tool that serves us. So we must keep looking at that as a tool and an instrument. And yes, it's integral, but how do we use it as a tool, and again, not as a be-all, end-all? Continuity of care and interdisciplinary communication are crucial aspects that have become important to healthcare across the board. This universal language transcends cultural linguistic barriers and really ensures that all team members are on the same page when it comes to any person's care plan. Thereby, effective communication is essential for delivering coordinated, integrated care. Continuity of care is critically important for our clients as they move through different levels of care, different specialists, different practitioners and providers. We want it to be a smooth transition. We want it to be effective and a smooth process for our clients, so that there is the reduction of the risk of medical errors, and that it's all about promoting their well-being. Interdisciplinary communication is a key to successful care coordination. Of course, all this collaboration can lead to more informed decision-making, improved patient outcomes, and a higher standard of care. There are challenges that still exist, right? Miscommunication, lack of collaboration, siloed approaches, right? But we need to continue to address these challenges openly and transparently, listen and learn from each other, and share and come to the shared place of the focus on the patient, the client, and their well-being. All of this, of course, within compliance to state, federal, legal guidelines and ethical professional guidelines. I think immediately of the privacy, HIPAA, sharing of health information, right? All the consents and the releases need to be in place. In the field of mental health, diagnostic assessments play that crucial role in treatment planning. We know that assessments help counselors and other professionals understand the root cause of our clients' issues, problems, and hopefully we're able to thereby determine the most effective course of treatment. So this concept of from blueprint to roadmap, diagnostic assessments provide that detailed map, that landscape of our clients, and guide us towards the most appropriate interventions. Diagnostic assessments involve a comprehensive evaluation of our client, their symptoms, their history, their current circumstances. We know that evaluation and assessment and testing includes various forms and methods that we've been talking about, and that by gathering all this from multiple sources and multiple methods, we can gain a holistic understanding of our clients' mental health challenges as well as their strengths. A key benefit of all this diagnostic work is the ability to provide a clear diagnosis, and that the diagnosis then serves as the blueprint for treatment planning, and that with our clients we can tailor interventions that really address their specific needs. They also help us as we are working on treatment goals with our clients, that we are establishing realistic treatment goals and that we're able to monitor progress over time. Also, identifying underlying factors that are contributing to our clients' issues. That too can help us develop that roadmap that maybe addresses, hopefully, these factors, these perhaps unique symptoms or issues pinpointedly directly. This roadmap will include interventions, right? Behavioral change strategies, coping skills, tools, all tailored to the client's unique personhood Additionally, diagnostic assessments and counseling help us identify co-occurring disorders and other underlying issues that may in fact complicate treatment. So the thorough assessment is in a comprehensive way, coordinated manner is essential. And that really is about the importance of diagnostic assessment, evaluation of our clients, and this whole concept of from blueprint to roadmap. Measurement-based care is an approach that involves using objective measurements that guide treatment decisions. This method allows us to track our clients' progress over time and thereby make informed decisions about their care based on data. The utility of measurement-based care lies in the ability to provide the providers, you and I as counselors and other providers involved in the client's care, insights into their condition and their treatment progress. By regularly measuring and monitoring key indicators such as symptom severity, functional impairment, quality of life, we can then tailor treatment plans to meet specific needs of our clients. This is a very personalized approach that can lead to effective, efficient care, ultimately improving patient outcome, client outcome, and improving overall well-being. Another benefit of measurement-based care is that it enhances communication between providers and clients, and providers and providers. Again, that collaborative approach that leads to better patient engagement, adherence to treatment plans, where patients are more invested, and that the right people are identified and collaborated with for the benefit of that client. So we know that diagnostic assessments are valuable tools in our client, for our client and for us. Not only important for identifying issues and providing interventions, but can also serve as that longitudinal marker to track progress. Thus, this concept of measurement-based care. Diagnostic data plays a crucial role in various fields. Data consists of information, right, that we collect through tests and assessments and observations, all these methods that we evaluate and analyze to better understand the condition, the symptom, the process of our clients. So the importance of diagnostic data really lies in its ability to provide valuable insights, to identify issues, to inform decisions, and drive improvements. Diagnostic data is used to identify and diagnose conditions, monitor treatment, make informed decisions. We know that within the field of technology, diagnostic data is essential for troubleshooting, maintaining the functionality of electronic devices and systems. Software programs and hardware components collect diagnostic data, and they use that to monitor performance, detect errors, and optimize their operations. Diagnostic data also helps improve product design, identify vulnerabilities, and ensures the quality and reliability of the technology products that we use and that our clients use. Diagnostic data is used to assess learning. So we have the use of diagnostic data in various aspects. And we know that these technological tools have really quickly emerged and advanced and blown up, I would say, in just the past year, more prominently as we think in terms of artificial intelligence or AI. Mental health care is a critical component to a person's overall well being, yet we know it is often underfunded and overlooked in resource allocation. The lack of investment can have serious consequences. One of the key challenges in resource allocation is the continuing stigma around mental illness. We know that individuals are often left untreated, undertreated, leading to poorer outcomes and higher costs. Another challenge is the fragmentation of services. Fragmentation makes it very difficult for individuals to navigate the system and to access the care they need. So, to address these challenges, it's essential to prioritize resource allocation. We talk about the importance of increasing funding for mental health, improving coordination and integration of services, all that address stigma and discrimination. But the other aspect of all this resource allocation is that it can also reduce long-term impact of disorders and save money, but also has a reach and investment into the development of you and I, those in the field as providers, in terms of training, in terms of support, in terms of research, to the development of ongoing new diagnostic tools and assessments, the use of technology for that work, different types of treatments, and theories and theoretical models and interventions that can be developed. But we know that that all takes money and time. We also know that there are some real important logistics and issues surrounding all of that and other aspects of what I've been talking about over the past couple of minutes in the past few slides, specifically compliance, regulatory, and of course ethics. All of these contribute, right, to the expansion and or the focus of resource allocation. Conducting a diagnostic assessment, focus and application. Diagnostic assessments are becoming more and more targeted and data-driven, as I discussed. Hopefully all this is helping us better understand both the presentation and the etiology and help us lead to referrals that we can really target at addressing a patient's concerns and that collaborative aspect of care. We have the theoretical influence that there are different therapies and therapeutic interventions and techniques that emphasize a very structured assessment process for targeting specific disorders, specific symptomatology within the field of mental health. I've painted a little bit of a picture. I mentioned about the holistic diagnostic process, right? That we are looking at things in a very person-centered but very holistic way, and that it's important that we continually adapt and strategize and pay attention to those nuances in our assessment, in our diagnosis, in our treatment planning with our clients. We have a professional responsibility and an ethical responsibility, so that we are doing no harm and that we are being faithful to assessment, the consent, the evaluation, and the treatment that's all sound and ethical across the board. So jumping back in a little bit to the DSM, the DSM-5 TR, the 5th edition text revision. Again, this we talk about the way that we're understanding the criteria and the categories that are used to classify mental health disorders in a different way in this edition, and that the manual is organized into sections that contains a specific disorder and then the respective diagnostic criteria. These criteria include symptoms, duration, severity, and other factors that must be present for the diagnosis to be made. One of the key aspects of this edition is the multi-axial system, again, that allows us to consider multiple dimensions of our clients and their care. So we're looking at specifiers and modifiers. They provide additional information about the specific presentation of disorder. And I know I went through a lot of this in a previous lecture about the specifiers, including details of onset, severity, how different factors and the modifiers have influenced the diagnosis or the treatment. We also have information on differential diagnosis that helps us distinguish between similar disorders and overlapping symptoms. So there's a lot of important, I think, tools, changes, and aspects of this edition that, while being faithful, I think, to the standardized assessment process, we're also allowing for, and there's the movement of some fluidity in terms of being able to navigate diagnosis and strategies for assessment and diagnosis in a way that is really working at being very patient client centered. Cross-cutting symptom measures are key components of this edition. These measures are used to assess symptoms that may cut across different mental health disorders, allowing for a more comprehensive, nuanced understanding of a person's mental health. One important aspect of cross-cutting symptom measures is their ability to capture symptoms that may be present in multiple mental health disorders. In addition to capturing common symptoms, cross-cutting measures also allow for the assessment of symptoms that may not fit neat and tidy, right, into a specific category. Cross-cutting symptom measures also are important for tracking changes in symptoms over time. We assess symptoms. We can monitor our client's mental health, how it's evolving, adjusting. The treatment plan then is needed. This can be particularly useful for our clients with very complex presentations and those with co-occurring disorders, thereby allowing for a more dynamic and personalized approach to treatment. Um, the the Diagnostic Statistical Manual Cross-Cutting Symptom Measure, the DSM-XC, is available online and in the DSM-5-TR. There's an adult and childhood version that's accessible through the APA website. We have, remember, we talked about the levels of assessment in one of the previous lectures. So we have the level 1 assessments, broad identification of symptom domains, that's preliminary assessment. The level 2, that's a detailed exploration of specific symptoms. And then the diagnostic tools that you can interact with in a way that complement and provide for, again, a holistic, comprehensive, but yet very appropriate, targeted assessment so as to improve an appropriate diagnosis and thereby treatment planning and goal setting for our clients. That all is impacted then through the informed decision making that we're able to make. We have the other supplemental diagnostic tools. We talk about how these are all enhancing our precision. They certainly have a very purpose-driven, applicable application, and that they also adhere to principles that are very ethical, very holistic, that are supported cultural sensitivity, right? They're interdisciplinary, and they look at the diverse needs of our clients. And they're, again, as I referenced a few slides ago, really that nuanced, personalized approach to counseling. There's some examples of the diagnostic tools. Incorporating diversity, equity, and inclusion in diagnostic practices and counseling is crucial for ensuring that our clients receive fair and equitable treatment. By taking this culturally competent approach to diagnosis, we can better understand the unique experiences and needs of our clients. One way is to consider the influence of cultural factors on our clients' mental health systems, and I know I talked a little bit about that too in a previous lecture. We need to acknowledge and understand cultural differences, and we can avoid making and misdiagnosing clients and provide more appropriate, effective care when we are paying attention to and learning about these cultural differences and taking into account our clients' cultural, ethnic, worldview, faith belief system. We need to also further address and be mindful of the other systemic inequalities and how they impact diagnosis for our clients. Our clients come from many from very marginalized communities, higher stress, trauma, discrimination, right? All this can contribute to the development of their mental health disorders and have an impact. So by recognizing and addressing these societal factors in the diagnostic process, we can better support our clients in our work with them. We also need to strive to create that welcoming, inclusive environment for our clients. paying attention to, again, the protective factors, both within culture and the cultural context, that also that are present in various frameworks like collectivist society models, religion and spirituality, also the cultural risk factors that are at play. I just mentioned those in the previous slide, incorporating tools to help us better identify these cultural risk factors. And then this nuanced understanding of the psychological distress, that culturally specific distress, how that then is identified and compared to symptoms in terms of mental health. And how do we differentiate in a way versus just stating or not taking those factors into account and just basing upon the symptoms as a standalone. Again, in the previous lecture, we looked a little bit of also some of these issues, continuing to address the unique learning needs of our clients, being considerate of their developmental, educational levels, with assessments, with the questions, with our methods of assessment and testing, right? All of these. And that we are targeted to make sure that our clients understand, not from our perspective, but from their perspective, what they're being asked to answer. Whether that's standardized, formal, informal, all the different types of assessments and testing that we've been talking about already in previous chapters. And that we're integrating these supplemental assessments, and that we again focus on our approach and outcome to be very client-centered and very collaborative. Now let's jump back to, I talked about the GAF in being replaced by the WHODAS 2.0, the World Health Organization Disability Assessment Schedule. This is a tool that's used to assess the levels of functioning and disability in individuals. It is a standardized measure that can be used to evaluate the impact of health conditions on a person's everyday life and activities. One of the key differences of the WHODAS and the GAF is that the WHODAS is more comprehensive, and it focuses on specific domains of functioning, like communication, mobility, self-care, interpersonal relationships, participating in society, right? So thereby we can really assess our individual clients through all areas of their life. So again, it's that comprehensive, holistic view into them and view of them. So it really becomes their own self-report, and that it is also not based on our observations, so that they are themselves able to provide insight into their own experience, that is our clients, and giving a more accurate representation of their functioning. The 6 domains that exist within the WHODAS are cognition, mobility, self-care, getting along, life activities, and participation. Again, we're looking at a person's health condition, their disability, and all and how it all impacts their entire life in a holistic, comprehensive way. Thereby, hopefully, we are gaining valuable insights and that we're able to make informed treatment plans, interventions, in a way that really is, again, client-centered and specific. Let's see. There's more on the HUDAS and the psychometrics of it. There are different versions and translations. It is tailored to various clinical and research needs. The issues of reliability and structure. It's a high test, retest consistency. There you see the coefficient and the alpha values. I mentioned the 6 domains. We have the sensitivity and validity. Again, I believe a good shift from the GAF. Diagnosing our client's condition and all that they're going through in terms of mental behavioral health is important. And we've been talking about that. And it requires skill, knowledge, and a deep understanding of our client's symptoms. And in fact, their entire comprehensive history, who they are. And all that helps us better accurately diagnose. So we really need to gather and synthesize data, diagnostic data. And diagnostic data is that information that we talk about being collected through our assessments, our tests, through exams and observations, etc. And then thereby, all this data, we can paint that picture of our client's condition, better understand the cause of their symptoms. So there's really this art of diagnosing that goes above and beyond this collection, but also critically thinking and the clinical expertise to interpret and thereby also arrive at an accurate diagnosis. We need to consider symptoms of our clients, and we need to rule out conditions. And that process requires that we continue to learn more and grow in our deeper understanding of human physiology, pathology, and science, especially neuroscience for us in the counseling field, and as well as our ability to think critically and creatively. One of the key challenges in the art of diagnosing is the fact that many conditions can present with similar symptoms, and we've kind of shared that a little bit ago. So in addition to clinical expertise, successful diagnosing also requires that we effectively communicate and collaborate. And we've talked about that a little bit too. Our clients are the best source of information. Their input is crucial. We need to listen carefully to our clients, probe with questions, involve them in the diagnostic process, ensure that we have all the information that we need so that an accurate, person-centered, client-centered, culturally informed, accurate clinical mental health diagnosis can be determined. Thank you.